Thank you very much, Udi and Chairman and distinguished members. First of all, thank you for inviting me to talk about the catheter-based valve-in-valve technique. I'm going to describe what we know as for the end of 2015, based on shared experiences from multiple centers around the world. So we've heard in the previous session that surgical bioprosthetic valves tend to fail over time. It tends to occur beyond a decade after implantation. The mode of failure could be stenosis, regurgitation, paravalvular leak, or mixed mode of failure. And reduced surgical or mitral MVR is feasible but associated with augmented risk and often occurs at advanced age. TAVI offers a novel mode of treatment for aortic bioprosthetic valve failure instead of reduced surgical AVR. And these are the two valves that got much of the attention and experience. On the left panel you have the Sapien, the balloon expandable Sapien valve in the valve-in-valve configuration, and on the right you have the core valve, and most of the discussion that I'm going to make is going to be about these two valves, although I should make a brief comment that over the last year and a half or almost 2 years, there are some growing data about some additional valves for valve-in-valve indication. So the VIVID registry, it's the largest contemporary registry that actually was originated at Rabin Medical Center 5 years ago. After we have performed our first valve-in-valve case, we decided to approach all the centers that are performing TAVI around the world and to run a prospective registry and to acquire data about the procedure and about the long-term outcome. We started with the aortic, then we moved to mitral and tricuspid, and by now we have more than 2,000 patients enrolled in this registry. Among those, 1,360 are with aortic position, and I'm going to review in brief the aortic as well as the mitral data, and if I'm going to have time, the tricuspid as well. So what do we know by now? And there are several publications, both in Circulation and JAMA, of last year about the VIVID registry data. The first thing that we know that this procedure is very effective. If we are talking about a bioprosthetic valve stenosis, so valve-in-valve can eliminate, actually not eliminate, but decrease the stenosis and the pressure gradient across the valve, and this is sustainable effect up to 1 year. So you have the pressure tracing here of the cohort, and also in patients with regurgitation, the valve-in-valve could improve or almost eliminate the amount of regurgitation, and I'm talking about intervalvular regurgitation and not paravalvular regurgitation. And yeah, but I can talk. And I know the data. And also this is associated with improved in the NIA class, so improved symptomatic improvement over time, which is again sustainable over 1 year, and we have now data which extend beyond 1 year. So this is an effective procedure. The time to failure varied. You see here the bell-shaped distribution. The mean is, and the median is around between 8 and 10, 11 years, but there are a lot of range here of aortic valve deterioration. These are the patient demographics. The mean age was around 77, 78 years. The majority of patients were male, but again, if you look at stenosis and regurgitation, and we distinguish between these two groups, there were more female in the stenosis group compared to the regurgitation. And the mean STS score, we started the registry with the mean STS score of 10.6, but it decreased over time, and now the mean is 7.6 or 7.4. If we look at the two groups, regurgitation and stenosis, the actual patients are not identical in terms of their body weight and BMI. The stenosis group had patients with larger body size implanted with smaller size surgical valves. So more patients in the stenosis group had a label size of equal or less than 21 millimeter. And you see here that when we distinguish between stented and stentless valve, the vast majority of the stenosis patient had stented valves, but almost 40% of the regurgitant valve, bioprosthetic valve, had the regurgitation within stentless valve. So the mechanism of surgical valve also dictates the prognosis. The stenosis group had higher mortality over time, over 1 year, with 23.4% mortality. The combined group is intermediate between the stenosis and regurgitation, and the prognosis of patients with regurgitation was favorable and much better compared to the stenosis. So if a patient has a bioprosthetic failure, it's very important to look whether the mode of failure is stenosis or regurgitation or combined, because it has some practical technical implications, and also it relates to the projected prognosis. Also, the surgical valve label size is important. Patients with smaller valve tend to have worse prognosis. You see here the mortality curve from any cause of patient with a label size of 21 millimeter or less compared to 25 or more, and in between the 21 to 25 millimeter group. We performed a multivariate analysis to correlate for 1 year mortality after valve in valve, and you see the independent predictor. So surgical valve label size of less than 21 millimeter was associated with a hazard ratio of 2. Baseline stenosis versus regurgitation was associated with a hazard ratio of 3. The transapical access was associated with a hazard ratio of 2.25, and the STS score was also associated with worse prognosis. The higher the STS, the lower survival analysis. What about the distinction between stented and stentless surgical valve? It is a very important distinction from many aspects, including the practical technical aspect, because you can understand that with stentless valve we don't have a sewing ring, so there is no marker for the operator to know exactly where to place the valve. And if you look at the rate of THV malpositioning, when we compare the stented versus the stented valve, so much higher rate of valve malpositioning or need for additional second valve within stented valve, with one exception, which is a mosaic valve, which is a stented valve, but it's also, because of its unique characteristic and design, also had a higher rate of malpositioning, but not necessarily higher rate of need for a second valve. And also the need for urgent intervention due to coronary obstruction was higher in stentless versus stented valve. If we look at the final mean gradient, it was 17.2 in stented valve versus 11.7. This was statistically significant. So the final result is stented valves is adequate in terms of residual gradient, but certainly it's much more challenging to perform a valve-in-valve procedure within a stentless versus a stented valve. What about the patient prosthetic mismatch? I told you before that patients with stenotic valve tend to have higher BMIs and smaller valves. So these patients are at higher risk a priori for PPM, for patient prosthetic mismatch. And indeed, in a sub-analysis of the visit, you see that about 1/3 of patients had no patient prosthetic mismatch, 1/3 of patients had moderate patient prosthetic mismatch, and the severe patient prosthetic mismatch occurred in 29% of the patient, almost 1/3, according of the definition of effective office area of less than 0.65 centimeter square per meter square. We don't know at that stage whether patients with a PPM have worse prognosis. This is not the case. We are underpowered to detect it, but this is an interesting finding if we want this procedure to be durable, not to 1 year, but for many, many years. It should be detected over time. Now, what about the implantation depth and gradient? A very meticulous analysis was performed by the group of Danny Dvir, who is now in Vancouver. He is practicing there, and they correlated the mean gradient versus the depth of implantation, both for the core valve as well as for the Edward valve. So what came out from this analysis is that the optimal depth of implantation should be equal or less than 5 millimeters. It means that when we perform a valve in valve, in order to diminish the likelihood of elevated residual gradient, we need to perform what we define as high implantation towards the aortic and not toward the LVOT. We can dive below the sewing ring, not more than 5 millimeters. If we are below that, there is higher likelihood to finalize the procedure with elevated mean gradients. What about Sapien? Same analysis, and again, higher implantation, which means not more than 10% of the valve dive towards the LVOT. Most of the valve should dive towards the bioprosthetic or even beyond. If we do that, the likelihood of ending the procedure with elevated mean gradient is small, but still higher compared to the core valve, and more than 10%, there is 45% likelihood of finalizing the procedure with elevated mean gradient. The results of the partner 2 valve-in-valve registry was presented just recently at the TCT meeting, and you see here again, very similar to what we found in the VIVID. The all-cause mortality at 1 month was 4%, at 1 year was 13%, the cardiac mortality was even lower, stroke rate between 3 and 4%, and rehospitalization rate at 1 month 7% and 12%. And again, in this registry, smaller valve tended to be associated with worse prognosis. And again, a patient with residual gradient, there was numerical difference, but not statistical difference, but again, underpowered study. It seems that if we want to perform the optimal valve-in-valve procedure, we would like to finish the procedure with the lowest residual gradients as possible. And in Europe and Israel, we are now performing the prospective VIVA trial, which is a prospective cohort of 200 patients with the core valve, the Evolute R now version, and we are performing and monitoring very carefully the results of the valve-in-valve procedure. Now let's move on to the mitral valve-in-valve, and the objective of the mitral arm of the VIVID was to evaluate the efficacy and safety of the mitral valve-in-valve and valve-in-ring procedure. The primary study endpoints is 30-day survival free from moderate or above mitral regurgitation or clinically evident LVOT obstruction, which is a particular hazard for this procedure. So in terms of the time from surgical mitral valve or ring implant, you see again the bell shape, the years from implantation, again around 10, 9, 8, 11 years. This is most of the median is 9 here. The baseline characteristics are also important. You see here that most of these patients are at advanced age. The STS score are much higher compared to what I showed you with the aortic position. So these are really patients at high risk for reoperation. This is the mode of failure. We have 45% with regurgitation, 23% with stenosis, and the combined gauge is about 1/3. But again, this distinction is different when we talk about valve in ring. Most of patients have regurgitation and few with stenosis, some with mix, and when we talk about the valve-in-valve, 41% have regurgitation, stenosis, and combined. So these are not identical population in terms of the mode of valve failure. These are the baseline echocardiographic parameter, relatively preserved LV function, not optimal. The maximal gradient reflects mainly the stenosis group and the valve area, again 1.4, 1.5, which is low to what we expect from a larger surgical bioprosthetic valve in the mitral position, and overall elevated PA pressure. When we talk about procedural characteristics, look at the mean residual gradient, which are between 5 and 6 mean, and the valve area we can get to 2 or even more if we talk about valve in ring. What about procedural outcome? The 30-day mortality is 8%. The mitral valve-in-valve is 7.7. The mitral valve-in-ring is 11.4%. The 30-day cardiovascular death is 6.9, 6% for the mitral valve-in-valve, and 10.2% for the mitral valve-in-ring. If we talk about the primary endpoint, which is again the composite endpoint, which includes 30-day survival free of significant MR, moderate or more, or clinically evident LVOT obstruction, you see here that the mitral valve-in-valve, the MACE-free event is 88.8% versus mitral valve-in-ring, which is almost 72%. So overall, the take-home message that the mitral valve-in-ring is a more problematic procedure for mitral valve-in-valve and also associated with less favorable outcome. I'll finalize with tricuspid valve-in-valve, also a growing experience. We have now in the registry 156 patients, mostly treated with either sapien on the melody valve. The mode of failure is either regurgitation or stenosis. The vast majority of the patients are very symptomatic, both right and some with left heart failure, and two-thirds of the patients, almost 70%, had the femoral approach. The jugular approach was adopted in 1/3 of the patient almost, and again we see that the procedure is very effective. These are the gradients overall and the mean and the range, so we can get rid of most of the tricuspid gradient in the stenotic scenario. In the regurgitation scenario, we can get rid in most of the stenosis with very favorable procedural results. And if we look at the survival analysis up to 3 years, we see that the mortality-free survival is favorable and almost identical whether it's sapien or melody. We look at the survival free from tricuspid valve-in-valve reintervention and the survival free from tricuspid valve-in-valve reintervention of significant tricuspid stenosis. Overall, favorable results over time in this very problematic tricuspid bioprosthetic valve procedure. At the end of the talk, I would like to thank the TAVI team of Rabin Medical Center. All these people are involved, and also Danny Dvir, who is a graduate of our program and also responsible to most of the data that I've just showed you. He's in very good contact with us, and we thank him and thank you for the attention. Thank you very much.